this is just a brief overview of what we're going to go through today. So GP emergencies, it's not a very big topic on the exam. I guess they could sort of give you an OSCE on it though. So if you happen to get an OSCE on it, this is sort of like a general approach that you can sort of go through. So first of all, obviously with the doctor's ABCD, so you want to make sure to stabilize the patient before you do anything else. Especially the asking for help part is really important. So hopefully you have people, within the room to help you out. And in real life as well, obviously get some help. Most GPs will have like a treatment room where they have specialized equipment, hopefully like oxygen stuff, ECG stuff that you can use. And once you've sort of stabilized the patient, you can go ahead and sort of examine it and perhaps take a history from them as well if you can, just to see what's going on. And then from there, once you've sort of have a rough idea what's going on and you've stabilized the patient, you can go ahead and do some other management as indicated, so investigations or going ahead with some further management. So I thought we might start off with a question. So feel free to message me your answer once you think you've got an idea. Yep, so I'm getting a few H's, which is good. Yep. So the answer in this case would be H. Some other options which might be tempting are like G, some morphine. So you might have heard of like the Mona sort of mnemonic for the management of a AMI. I guess it's good to remember that in this case, you are in a GP. So might be a bit more difficult to get IV access in. Some GPs can get IV access, but I think it'd be more practical to get to give oral aspirin first. So probably go with that first. So in terms of AMI, so the immediate steps, sort of same as what we talked about before, but obviously the main sort of investigation that we want to do is an ECG. Most GPs will have an ECG machine, hopefully. In terms of initial management, so sort of the Mona we talked about, again, if you can't get IV access in, that's all right. Some GPs might have IM morphine available, or hopefully just give them some oral analgesia. Oxygen if that's a low, and aspirin as well. And just be careful with the GTN sprays. So some questions, like in the question before, it shows sort of ST changes in the inferior leads. So you want to be careful when giving GTN spray if someone has an inferior MI, because it can sort of worsen their hypertension if they have any. Just be careful of that. Cool. And while you're waiting for the ambulance, you can repeat your ECG and vitals just to make sure that they're stable. So with the role of troponin, so in a metro setting, you don't typically do troponin as a GP. The reason for that is because, let's say someone comes in with like chest pain, nausea, vomiting, sweating, etc., and you think it might be an AMI, right? So let's say, for example, you do a troponin, right? So you got to write up the troponin slip for them. You got to hand it off to the patient, and then you got to tell the patient to go to the pathology place. Then they're going to drive to the pathology place. They're going to wait around to get a blood test. They got to get the blood test done, and then they go home. And then let's say the troponin does come back positive, then the pathology place has to call you. You got to call you got to call the patient. The patient has to drive to the hospital, etc. So basically, the point is that there's going to be so much delay between the time of symptom onset and telling the patient to go to the hospital that the patient might have already died by then. So if you're concerned about an AMI in a metro setting, just send them to the hospital right away. So like in an exam question, for example, if you're in a metro GP, and someone comes in with AMI symptoms, it's very unlikely that the option is going to be like do a troponin, as if they ask, for example, like what's the next sort of appropriate step. There are some potential scenarios where you can do a troponin. So if they sort of have vague symptoms in the preceding days and they come to you and they're sort of asymptomatic, but you're still sort of a bit unsure and you think that they could have had AMI, which is sort of resolving, then you can do a troponin. Or if they have a low sort of pretest probabilities and you want to sort of cover your bases and roll it out. Rural is sort of a bit different because some rural settings you might not have access to a hospital close by. So you can do what's called like a point of care CHOPS, which is basically like a bedside sort of troponin sort of test. And that can be done to sort of triage patients and sort of determine whether you need to send them to the hospital or not. I won't go through this in detail. I don't think it's very examinable either, but I guess if you were to remember one thing, maybe just like the ratio of the compressions and breaths. So in adults, it's 30 compressions and 2 breaths, whereas in children and infants, it's 15 compressions and 2 breaths. Cardiac arrest. So again, I don't think the details of this are very examinable, but I guess if you had to remember one thing, it's maybe the dose of the adrenaline in cardiac arrest. So it'd be 1 milligram of adrenaline. So that can be either IV or IM, I think. So if you can get IV access, then I think it's better to give it IV, but otherwise IM is also fine. Yeah. And some causes of cardiac arrest as well. Again, I won't go through that in detail, but just there for you to have a look if you'd like. Okay, next question. So I'll let you guys have a read and then have a go at it when you're ready. Give you guys about 5 more seconds, maybe. Cool. So the answer in this case is A, so IM adrenaline. So this patient is undergoing anaphylaxis. So there's a precipitant, which is the bee stings, and then he's sort of developing respiratory symptoms like shortness of breath, facial swelling, and some skin symptoms like urticaria. So yeah, anaphylaxis is sort of like basically like a severe allergic reaction. So it can feature symptoms from basically multiple systems. So like cardio, rest, GI, so like the typical shortness of breath, stridor, that sort of thing. Hypertension is a key one. So a lot of anaphylactic patients will become hypertensive. So that's why sort of giving like a IV fluid bolus is really important. And skin features as well. So urticaria or angioedema, which is sort of swelling around the lips. Medications, one of the most common causes, but stuff like foods and insect bites like bee stings can also cause anaphylaxis. It's very important to remember that adrenaline is always given IM in anaphylaxis. So I guess in an exam, if they're feeling tricky, they might say, oh, the patient has like IV access, or you can get IV access in, etc. What medication would you give them? But the answer is still IM adrenaline, right? So you'd never give IV adrenaline for anaphylaxis. You'd only give IV adrenaline for a cardiac arrest. And I think the dose is good to remember as well. They like to drill in the dose for us in fifth year anyway, so it's good to memorize the dose as well. So it's 0.5 milligrams, essentially, which is 0.5 mils of 1 in 1,000 adrenaline. Yeah, and then sort of just like the IV access that I was talking about and giving IV fluid bolus if you can. Cool. So I think Esther might have touched on this briefly in her lecture, but essentially someone comes into your practice with sort of like an exacerbation of asthma. You can try the 4x4x4 rule. So if you don't have a spacer, then you would give him 4 puffs of salbutamol, and wait 4 minutes, and then give him another 4 puffs. And if the second round of 4 puffs doesn't work, then you'd call the ambulance right away. If you do have a spacer, it's a little different. So you give 1 puff into the spacer, and then you tell them to take 4 breaths from the spacer, and then repeat that 4 times essentially, for a total of 4 puffs. Wait 4 minutes, and then do another round of those 4 puffs. And then if that doesn't improve, then you call the ambulance. Is it anaphylaxis or asthma? So this is just basically a fancy way of saying if someone has a history of asthma and they come in with sort of shortness of breath, wheezing, that sort of thing, and you're sort of unsure of it, whether it's sort of anaphylaxis or asthma, just treat it like anaphylaxis anyway. You're not going to get called out or get in trouble if you give them adrenaline and it happens to be asthma. So it's better to be safe than sorry in these sort of cases. And the other thing I wanted to mention is that you might have sort of seen some asthma management guidelines where it's like, oh, if they're under 6 years old, you give them 6 puffs of salbutamol, 4 puffs of ipratropium, and then if they're above 6, you give like 12 puffs of salbutamol, 8 puffs of ipratropium, etc., that sort of thing, and then wait 20 minutes and then repeat if necessary. So that guideline is only for sort of the acute hospital management of asthma. So if they're in the hospital and they can be monitored, you can follow that sort of protocol. But if you're in the community or in a GP, then it's not as practical. So you want to follow that 4x4x4 rule. I guess the other thing I wanted to mention is that I guess it's unlikely that you'll have an OSCE where a patient comes in with like an exacerbation of asthma and you got to do the sort of 4x4x4 rule. But I guess where this could come up is sort of when a patient comes in with asthma and you've got to do the 10-step management plan. So the whole DK empire sort of thing. So you can explain to the patient sort of what the steps are if they do get an exacerbation. So that's a 4x4x4 rule. So good thing to keep in mind, I guess, for explaining the management of asthma. Cool. So status epilepticus. So this is basically either a prolonged seizure or repeated seizures, and the management is this benzos. So you want to try IV midaz or diaz first, and then if you can't give IV access, there's multiple ways to give the benzo, but IV would be ideal. And then you wait 5 minutes. If that doesn't work, give it again. Wait another 5 minutes. If that doesn't work, then you can go ahead and try your second line drugs like an anti-epileptic. And I guess just some considerations. Again, let's say if someone comes in with a seizure and then, or maybe not coming with a seizure, but let's say they come in post-seizure from a hospital and you got to like explain to them what the sort of management guidelines are. So this is what you can explain to the patient if ever they do get a seizure sort of episode in the future. So yeah, don't restrain, remove all the surrounding dangers, protect their head with like pillows and stuff. Yeah, that sort of thing. Cool. Hypoglycemia. So you guys probably be familiar with the symptoms. So agenetic symptoms are related to sort of the release of adrenaline from the body to try and sort of increase the mobilization of glycogen essentially to get some more energy in. And neurological symptoms as well, just because the brain isn't getting enough glucose essentially. I think another common trap is that a lot of people would tend to go for sort of glucagon or glucose as their sort of management protocol, even if the patient's conscious. So typically if the patient's conscious, you want to try oral carbohydrates first. I mean, I guess glucagon and glucose can work, but I guess it's a bit overkill. It's a bit unnecessary. So you want to try and give carbohydrates first before you do anything else. And then, yeah, so try 15 grams first and then wait 15 minutes. If the blood sugars are still low, you can repeat that 15 grams of carbs. If they're unconscious, that's a different story. In that case, you can give your glucagon or glucose. Yeah, just make sure to sort of read the statement of the question. So if it says that they're conscious, then you're probably not going to be looking at glucagon or glucose as your sort of first line management. Cool. And I won't go through this in detail, but you can sort of have a look in your own time. So sort of the common symptoms of certain overdoses and their management. Ooh. So that was the GP emergencies part, pretty quick. So I think this would take up most of the lecture. MSK. All right. So this is something that I'm always confused about, and I still am to this day. So sort of what investigation to pick for what sort of injury you have. So I've sort of written down here like a rough sort of guideline for what imaging you would choose for what type of structures you're concerned about. So starting off with X-ray, so we all know that it's good for bone, but it can also be used for assessing like the joint spaces. So we know that can be used in like osteoarthritis, and if someone's you think someone's dislocated one of their joints. And the CT is basically like a 3D X-ray, right? So it has very similar indications to an X-ray. Like it's very good at assessing bone, joint space as well, and it can be used to assess sort of subtle fractures more easily as well. So if you think someone has a fracture and you can't find it, then on the X-ray, then you can go ahead and do a CT, and that has high sort of sensitivity for that. An ultrasound, so it's better for showing soft tissue as opposed to bone. So sort of more superficial structures, like your tendons and your muscles, and motion sensitive pathology. So that's basically a fancy way of saying pathologies where you need the patient to sort of move the affected joint or structure in order to elicit the symptoms, right? So let's say you've got like an impingement of like one of your shoulder joints, then the ultrasound would be good for that. And an MRI, it's also good at showing soft tissue, but sort of more deep structures. So you can think of ultrasounds as being sort of like short-sighted, whereas MRIs are a bit long-sighted, right? So if the structure's up close, like near the skin, then ultrasounds are pretty good. They're not good at showing structures that are more deep, whereas MRIs are sort of the opposite, right? So if it's close to the skin, it's still pretty good, but it's not as good as ultrasound. But where it really shines is sort of the deep structures, like all the ligaments inside your joints, stuff. So yeah. Cool. So I might have a look at this question. Feel free to message me your answer if you think you've got one. I think this is actually pretty tricky. I feel like the answer is a bit controversial. I said, if you want to have a go as well, because I want to get your opinion.
Oh, I remember this question from last year.
Okay. So, alrighty. Okay, got a good range of answers, which is what I expected. So it's a toss-up between B, C, and G. Okay. Now, the faculty official answer is C, but I actually think the answer is C. And last year's lecturer seemed to think the answer was C as well. So I'll sort of go through my thought process, right? So I guess the first thing we have to consider is sort of what structure has been affected, right? I guess we'll go to the next slide and that sort of explain my thought process a bit more. So in terms of sort of shoulder pathology, there's two main things that we have to be aware of for sort of MSK pathologies with the shoulder. So that's rotator cuff tear and rotator cuff impingement. So a tear is sort of a tear in the muscle, right? Whereas an impingement is sort of where there's pain when the shoulder structures are sort of put in certain positions because the bursa or the tendons are sort of impinged or sort of squeezed in between the structures. And that usually occurs with sort of bursitis or tendonitis. So if you've got a tear, on examination, you'll have pain and weakness on your resisted movements. So depending on what sort of muscle is torn, there's certain exams that will elicit pain and weakness. Whereas with impingement, you'll get basically pain and weakness, so more pain, basically when you put your shoulder in certain positions that will, impinge upon the structures, right? In a normal person, it wouldn't cause impingement because our bursa and tendons aren't inflamed, right? So there's enough space for everything to move around. But if someone's got bursitis and tendonitis, there's less sort of space in the shoulder joint for everything to sort of coexist. So in certain ranges of motion, you'll get pain there. And the thing with this is that rotator cuff impingement is usually a clinical diagnosis, right? So usually won't need any imaging for an impingement. For a tear, you can consider ultrasound or an MRI if wanting to do surgery. The management is basically the same between both of them, except in a tear, you can consider surgery if it's like a really bad full tear. There are surgeries that you can do for impingement, but they're not as good, so people don't tend to do them. So usually the management is more conservative. So anyway, going back to the question, because he's got pain in the painful arc, sort of that second last sentence there, I was thinking that it'd be more of an impingement. So therefore, you probably wouldn't do any imaging. But I guess like in real life, you probably would be wrong to do imaging because, the diagnosis is a bit sort of unclear.
Yeah, I remember doing this exam. I originally thought it was C as well. Reading it now, I do wonder, just because of the history of it being like that he got the pain immediately after that in action, you wonder if maybe they're trying to get you to think about kind of a tear, in which case maybe we need to be considering surgery. But yeah, the examination's a bit odd there. So I don't know. I think it's not a great question. In real life, this guy's probably going to get an ultrasound because
I agree,
we often do kind of investigate more than maybe we need to. But yeah, it's not a very good written question, I don't think.
Yeah, I agree. In real life, I'd probably do an ultrasound, but exams, who knows? But yeah, you're right. So we go back to the slide. So if someone has acute trauma, they're more likely to get a tear rather than an impingement, whereas impingements are usually sort of gradual onset, so sort of due to chronic shoulder overuse that can over time cause inflammation of the bursa or the tendons. Just some more sort of differentials to consider. So I guess the main ones here would be adhesive capsulitis and PMR. So frozen shoulder is typically characterized by progressive loss of range of motion, both passive and active, right? So if you have loss of motion in both active and passive, you're probably thinking more of like a intra-articular or sort of joint issue, as opposed to if you only lose range of motion with active movement, right? Because that's more of a muscle issue. Something to think about. And then, PMR can also present with sort of stiffness, but this is usually bilateral, whereas with frozen shoulder, it's usually unilateral. And there's no pain in PMR either. Or there might be, but it's less common. And you might see some questions where they can have shoulder joint instability as an option. So the buzzword here is sort of if someone's, let's say, like a swimmer or like a baseball pitcher, sort of like a sport or like a job which requires them to put the shoulder in basically like a range of motion which is further than what a shoulder's typical range of motion would look like. Yeah, and the buzzword there is positive apprehension test. Labral tear, I personally haven't seen any like questions on it, but I guess they could include it in. So similar to, I guess, shoulder joint instability. So if someone's like a baseball pitcher or something like that, but it's more of like an acute thing. So they could hear like a clicking or like a grinding sort of sensation as soon as they pitch the ball. And that needs an MRI. Cool. We're going for time. Yeah, pretty good. Cool. Let you guys have a go at these questions. Cool. Might give you guys like 10 more seconds maybe. Alrighty. Got a range of answers here. So go through the answers. So for question 12, it's G, and for 13, it's C. So the reason why question 12 is G is because the radial nerve runs through the mid shaft of the humerus. So I think this is sort of just like an important, I guess, fact that faculty wants you to know. And 13, so I think the main sort of structure which is around that area would be the brachial plexus that you'd be concerned about. I guess the arteries would be a valid concern as well. But I think the brachial plexus is a bit larger, so it's more likely to be affected, I think, is sort of what my reasoning was. Cool. So I guess in terms of shoulder or sort of humeral injuries, there's certain sort of structures to be aware of if you think someone's injured it. So if you've got a surgical neck of the humerus fracture, so most likely nerve to be damaged would be the axillary nerve. And if you can recall, that controls the deltoids primarily. And the deltoids are responsible for shoulder flexion and abduction. So someone presents with a surgical neck of humerus fracture or like a query surgical neck of humerus fracture, and they have weakened flexion and adduction of the shoulder, you might be thinking that the nerve is damaged. Yeah, they could sort of ask the question the other way around as well, right? So there could be like a patient comes in, they fall on their outstretched hand or something like that, and they get weakened shoulder flexion and adduction. What's the structure that's damaged / what structure is most likely to be fractured? So yeah, the answer to that would be the surgical neck of humerus. And then the humeral shaft fracture. So the radial nerve runs through that. So and the radial nerve is responsible for finger extension and sensation, sort of like at the back of the hand as well. I guess one key clinical point here I want to make is that it's good to sort of test the neurovascular status of all the distal structures if you've got like an injury up even like proximally in the arm, right? So what I mean by that is like, let's say you get like a shoulder injury or like a humeral injury. A patient comes in with like, pain in the bicep or the shoulder or something. It might be tempting to just sort of test the structures around that area, like the elbow and the shoulder. But you want to make sure to test distally as well, right? So you want to make sure to test the hand as well. Because the nerves that supply the hand will obviously run through that area as well. So yeah, good thing to keep in mind. Cool. This is my favorite way of testing the neurovascular status of all the nerves that supply the hand. It's good for kids as well, because it's like, you don't have to tell them to do anything. You just ask them to play like rock, paper, scissors with you. So in order to make a rock, you need to be able to flex all your fingers, which is what the median nerve does. For paper, you need to be able to extend all your fingers, which is what the radial nerve does. And then in order to make a scissors, you need to be able to abduct these two fingers and bend these two ones, the fourth and the fifth finger. So that's what the ulnar nerve does. So yeah, I find that a good way to sort of test all the nerves that supply that. Cool. Just pain. So yeah, I'll let you guys answer these questions. Maybe give you guys like 10, 15 more seconds. Got a few answers coming in, which is good. Yep. So for question 4, we've got a mix of, actually no, we've got mainly B. Question 5, yep, mainly H, and then question 6, got a mix of answers for question 6. So we sort of go through the answers. So B, H, and C. So carpal tunnel. So carpal tunnel is often associated with pregnancy, because I think you can get swelling. You're more likely to be prone to swelling and stuff in pregnancy. And if that swelling sort of builds up in the hand, that can sort of compress on the median nerve. And that there's sort of like the median nerve distribution as well. So the right thumb and index finger. I think that's also a buzzword as well for carpal tunnel. So worse at night and relieved by hanging her right arm out of the bed. I think that will sort of help to decrease the swelling. So relieve the pressure on the median nerve. Question 5. So yeah, the typical buzzword for a scaphoid fracture would be the pain in the anatomical snuff box region. And question 6, I think this one was a bit more tricky, but essentially the answer is C. So if I was doing this question, I'd probably toss up between maybe like C and I, just because of like what seems to be like neuropathic type pain. So I might be thinking an issue to do with the nerves. The reason why it's C and not I is a bit niche, but essentially cervical radiculopathy is more likely to affect the upper roots of the brachial plexus. So sort of like the C5, C6, maybe the C7 region. So that distribution there, sort of the thumb and index finger region, that's sort of like the C6 region. Whereas thoracic outlet syndrome is more likely to affect the lower roots of the brachial plexus. So sort of like the C7, T8, T1 sort of distribution. It's more likely to maybe get symptoms in your pinky finger and your forefinger. Yeah, less likely to get symptoms in the thumb and index finger. Cool. Yeah, sort of just going through what I was talking about before. And then I guess the other one we haven't talked about is de Quervain's tenosynovitis. So there's a few buzzwords for this one. So the main one is like the positive Finkelstein test. So as you can see, that sort of test there. And if that elicits pain, then they probably have tenosynovitis in that sort of tendon. Cool. Okay, back pain. I'll let you guys have a go at these. Could you please repeat which diseases are affected by upper? Yeah, sure. So cervical radiculopathy. So that's more likely to affect the upper roots of the brachial plexus, so C5, C6, C7. Whereas thoracic outlet syndrome, that's more likely to affect the lower roots of the brachial plexus, so C7, C8, T1, that sort of area. If that helps. Give you guys like 10 more seconds, maybe.
There was just a question about one of the previous questions as well, which I might just explain if you're happy to go back to that slide quickly. Was just talking, asking about the difference between J, trigger thumb, and D, de Quervain's tenosynovitis. So the de Quervain's tenosynovitis, yeah, I think you've kind of got it there, but that particularly affects the base of the thumb, whereas trigger finger can kind of happen in any of the fingers and makes it kind of difficult to kind of straighten out the finger. So it's just like a slight difference, really. But
yeah, thanks, Esther. Yeah, and I think one of the other main differences is sort of like the clicking/locking sensation, which would occur in trigger thumb, but wouldn't really occur in tenosynovitis. You'd probably just get pain. Yeah. Cool. Yeah, so the answers for these ones are G and E, which I think pretty much everyone got, which is good. So in G, you'd be concerned about cauda equina, mainly because of the urinary incontinence and the reduced anal tone. And cauda equina is an emergency. So you want to get them assessed straight away in the ED. And yeah, pretty much everyone got 43 as well, which is E. So I'll sort of go through the next slide. There's a lot of information here, but essentially, so one of the main causes, or not the main cause of back pain is musculoskeletal, right? It's what we call non-specific lower back pain, and that accounts for like about 90% of back pain. Right? And in those cases, you don't want to do any investigations. You only want to investigate if you've got basically one of these red flag symptoms here. There's a long list of them, but I guess it'd be more helpful to sort of, for me to consider what isn't a red flag, right? So what isn't a red flag? Severe pain with a trigger isn't a red flag, right? So in this case, they've got a clear precipitant of sort of unaccustomed trench digging, right? So it's pretty likely that that's going to be the cause of the pain. So because you know the cause of the pain, you probably don't need to investigate. And the other thing is weakness, right? So unilateral weakness anyway. If someone comes in with like unilateral pain and weakness, you might think it's pretty bad, but you actually don't need to investigate for that either. But if they've got any of these stuff, then yeah, send them off for a X-ray or MRI, depending on what you're concerned about. And I guess the other thing is that it's good to sort of consider other causes of pain that aren't really related to the spine, like sort of renal stuff, prostate stuff, that sort of thing. That can be around that general area as well. Yeah. And I guess in sort of like an approach to the musculoskeletal non-specific lower back pain that I talked about. So I think a lot of this is just reassurance. So obviously patients will be very scared. Going to be in a lot of pain. They're going to be like, oh, am I going to get better? Why aren't you doing any imaging for me? That sort of stuff. So you really want to make sure to reassure them. Say, want to reassure you that it's a very common condition and it should settle by itself over time. If it doesn't settle by itself, then that's where you can sort of start to think about other differentials, like sort of the red flag conditions we have there. But yeah, a lot of it is sort of just conservative management. And in terms of pharmacological management, you can give them simple analgesia and probably don't go above there. So in other words, probably don't give opioids, anything stronger. Yeah, it's probably just unnecessary. And those are sort of specific management of some of the certain red flag conditions that we discussed earlier. Okay. What is the common mechanism of action of injury for declamains? My understanding is that it's more of like a chronic overuse thing. I guess you can get declamains if you sort of like, I don't know, bend your wrist back and forth a lot, like acutely. But I think it's more of like a chronic thing. So like if you ride a lot, for example, or maybe if you like go to the gym and do a lot of wrist exercises. Yeah. Does the time interval between the known trigger? So the pain happens immediately compared to severe pain after day working. I'd probably say no, because yeah, some patients can notice the pain like right away, whereas others, due to several reasons, like it could be psychological, like they could be distracted on something else, and then as soon as they're not distracted, they can sort of notice the pain, right? Or sometimes like if you have like DOMS, like delayed onset muscle soreness, like that can take a while to sort of develop, right? Yeah, so I'd say that if there is a trigger, if you think there's a clear trigger, the time of onset shouldn't matter too much in terms of like separating between like immediately versus like a day or two. Obviously, if it's like a week after or like a few weeks after, then you might be concerned about something else. But yeah, I think a few days shouldn't really make a difference. Yeah. Cool. Yeah. Let you guys have a go at these. I think these questions are really mean, by the way. Like these sets of questions, yeah. Like so, yeah. But we'll see how we go. Oh, bonus points if you can give me the diagnosis for each one. Okay. Got some answers coming in. If you guys maybe like 15, 20 more seconds. Ooh, maybe like 5 more seconds. Okay, all right. Got a wide mix for all of them essentially, which is sort of what I expected. All right, here are the answers, and with the corresponding diagnosis. Right. Yeah, they don't typically tend to put the same answer for 2 questions in a row, which is why it's really mean. But yeah, so we'll go through each of them. So trochanteric bursitis. So that's sort of associated with pain over the greater trochanter, essentially. And you don't need any investigation for that because usually the diagnosis is quite obvious. G, so sorry, the second one. So that the answer for that is also G. So I don't know if you guys have actually heard of this before. I've seen it once in my GP rotation. That was this year, not last year. Yeah, but essentially the buzzword for that is sort of neurological symptoms over the lateral part of the thyroid. And it's caused by compression of one of the nerves, which I'll sort of go through next slide. But anyway, you don't need to do any investigations for that either. And these are hip fractures. So inability to weight bear is pretty concerning. I'd be pretty concerned for a fracture there already. No history of trauma falls. That can point away from a fracture, but she does have a history of dementia as well. I mean, I'm not sure if it's self-reported, but anyway, in these sort of patients, well, they also have hypothyroidism and absorption. So I think they wanted to point towards something like osteoporosis, which could, again, increase the risk for a fracture there. So I think that's why the answer is D there. Yeah, these questions are kind of mean, so don't stress too much if you didn't get the answers. Cool. A lot of causes for hip pain. I don't think you would have to remember all of them. Probably won't. The main things to consider are fracture. So any of these ones. So fracture, muscle strain / tear, and avascular necrosis. And then maybe like OA and inflammatory arthritis, because those are sort of both pretty common. Yeah, the rest you can sort of just remember the buzzwords, which I have in the next slide. The red flags, so they're actually pretty similar to the red flags for back pain, but just with a couple extra ones added. So stress fracture is something that you commonly see in the hip as well. So the buzzword for that is like, let's say you have a runner who they're usually sort of running regime consists of like 10 Ks a week, and then all of a sudden they increase it to like 20 kilometers a week or something. So that sudden increase in physical activity can predispose you to a stress fracture. Avascular necrosis is the other one as well. So some of the buzzwords are like smoking, alcohol, and steroid use. So remember that I think the head of the femur has retrograde arterial supply, something like that. Cool. Yeah, again, you won't have to remember these in detail, but I think it's good to just remember like the parts in red. So especially like where they are, and then from there you can sort of hopefully figure out the rest. So yeah, so I guess I'll just go through a few things. So with the labral tear, so sudden onset anterior hip pain. So if you recall, like it's pretty similar to the labral tear in the shoulder, right? So you'll get like a clicking / grinding sensation after like a sudden traumatic activity. The investigation for that is MR arthrography, which is basically just a fancy way of saying MRI contrast. So basically injecting some gadolinium, which is like a special type of contrast into the joint, and that helps you sort of visualize it better. You'll sort of notice for most of these as well, you don't do any investigations, right? So basically, like, if you're sort of unsure of the diagnosis, I'll probably just pick no investigations, because a lot of hip stuff, you don't really need any investigations. So it's mainly sort of like the red flag sort of things that you need to investigate for. Everything else, you can probably go by without investigating. Yeah, cool. I was going to leave this out because I thought it was pretty low yield, but there's a past question in it apparently, which is a bit mean, but yeah. Oh shit, no. Yeah. Okay, the answer is C. Yeah. So anyway, these are I'll sort of go through the rules. So I guess you might be tempted to pick maybe like D, right? Because you might be concerned about a fracture. But essentially, there are certain rules to sort of tell you when you need to investigate for a suspected ankle fracture and when you don't need to. Here are the rules. I think it's very mean of them to make you memorize these rules off the top of your head to answer these questions. Yeah, you can sort of just base it on vibes as well if you want. Like, if you've just got swelling and tenderness in sort of one area of the joint, just the anterior aspect, then it's less likely going to be a fracture. Whereas if you've got sort of pain/tenderness on multiple areas of the foot, then you're more concerned about a fracture. So yeah, basically the more areas that are in pain, the more likely that it is that it's going to be a fracture. And also the fact that he's able to weight bear when you examine him. So if you have like an acute sprain, you might not be able to weight bear immediately, but as the swelling sort of subsides, you can weight bear. Whereas obviously with a fracture, that fracture won't subside that quickly. So when they present to you, they're still going to be unable to weight bear, essentially, which is what that third line there sort of says. Yeah, just a sort of visual view of what we covered. Cool, knee pain. Let you guys have a go at this. In the last case, because he wasn't to weight bear initially, does that not warrant an X-ray? So if you sprain your ankle and it's pretty bad, then you might not be able to weight bear immediately. But after a while, as the sort of initial swelling sort of fades, you might be able to weight bear. Yeah. So you won't need an X-ray for that. Cool. Oh, I can't see the end of the question. Oh, that's it. Says, yeah, that's right. on examination, there's prominence of the patella and sagging of the tibia. I don't know why that's cut off. You guys like 10 more seconds. Okay. Cool. So here are the answers. Cool. So for question 80, so bursitis, so it's very commonly associated with sort of pressure on that joint, right? So if you can imagine like resting your knee on the floor, or you can often get bursitis in the elbow as well if you're resting your elbow on the shoulder too often, like if you're sort of typing or like writing all day. 81. So the buzzword for meniscus tears is twisting injuries, right? So if someone presents with a twisting injury, then you want to immediately think about a meniscus tear. And 82, sorry, the end of the question was cut off apparently. But yeah, the main thing there is like prominence of the patella and sagging of the tibia. So that's basically like the posterior sag sign, right? Which is a indicative of a PCL tear. Cool. Why is 81 on a medial meniscus? Wait, yeah, you're right. Yeah, it probably should be medial meniscus. I'm not sure. Yeah, I'll probably have to fix that. Yeah, you guys are right. Yeah, it should be medial meniscus. Cool. Yeah, just a lot of information. I think you can go through in your own time, but I guess yeah. I think the parts in red would be good to remember. So sort of like the buzzwords on the exam for each of them. I think in real life, most of these guys will get an MRI. But apparently you only do it if the diagnosis is unclear. Yeah. And then the other main thing is that if you've got an ACL or PCL tear, usually you can't weight bear. So if a question states that the patient's still able to weight bear, then it's less likely that it's going to be one of those tears. Cool. Just some more buzzwords. Won't go through for the sake of time. Yep, some rules for imaging. Cool. In the interest of time, we might skip this. You can go through it in your own time. But yeah, they're mainly just buzzwords. Okay, and I think this is the last topic. You guys maybe 10 more seconds. Cool. Yep. So question 29 is I. So NSAIDs are basically, first of all, the diagnosis is gout. And NSAIDs would be sort of the first line option for the management of acute gout. And question 30 is H. So he's already been getting sort of acute gout flares, and they're not sort of controlled on just simple analgesia. So you want to start them on allopurinol for sort of some chronic management. Okay, cool. Yeah. So I think you guys would have received a bit of teaching on gout already, so I won't go through it in detail, but just some things to consider. So I think risk factors are good to keep in mind because like an exam question would often include those sort of risk factors. So, you know, like a patient with a history of like CKD or on chemotherapy before this or that. So if they have one of those risk factors, it's more likely to be gout. Precipitants as well. So risk factors are sort of factors that lead to you developing gout, right? So going from not having the condition to having the condition. Whereas precipitants are more sort of factors that would cause you to go from like having stable controlled gout or asymptomatic gout to like an acute flare-up, right? So I guess how they might phrase it in the exam is like, you know, a patient on a background of like CKD, he goes on like an alcohol binge and then gets pain in his big toe. It's most commonly in the big toe because there's less circulation there because it's furthest away from the heart. So it's going to be colder there, which would predispose to crystal deposition and formation. Bloods, yeah. Just be careful with measuring uric acid levels because in an acute flare, uric acid levels could actually be decreased because, as you can imagine, all the uric acid is in the joint itself, right? So there's not much of it left in the serum to sort of measure. Yeah. And also with the acute management, so I think a lot of us will remember sort of colchicine as sort of one of the mainstays of acute treatment, but according to ETG, that's actually last line. So you want to try NSAIDs and steroids first before you go into colchicine because it's basically like a pretty dirty drug, right? It's got a lot of side effects, especially like GI side effects like diarrhea. So you don't want to put someone on colchicine unless you have to. Yeah. Cool. And cool, I think that's it. Just some more resources for you guys if you'd like. So MCQs from last year and our general GPSN drive. Cool. Good luck for exams, guys. Thanks for watching. If you guys have any questions, feel free to